Morning. I'm going to start with what Russell mentioned about with the COVID units and the PUIs and how we're designating them in the hospital currently. So we've had, as you know, and Russell alluded to as well, increasing information about the sporadic testing ability or the shedding of the virus in individuals, that asymptomatic carriers might be shedding the virus and exposing others to it. Even people that have the virus may be shedding on one day and not on another day. So there's a lack of clarity on what's going on there. So our PUI patients that come into the hospital and they're having respiratory difficulties, or anybody who comes to the hospital with respiratory difficulties requiring critical care management, they'll go to the critical care unit. And if we think that they may be a PUI patient, they'll be in the COVID ward of our critical care unit. Medically managed patients that don't require that level of care will be on our COVID medical unit. And when they have their initial COVID test come back, if it's negative, they'll remain there. We have been moving them out, cohorting them, and only if there are no designated positive test. We're recognizing that that may not be as accurate as we'd like it to be. We don't want to expose any of our staff unnecessarily if we find out later that somebody who was initially negative turns out to be positive. So it's going to increase the numbers over time in those units, and as long as the patient's in the hospital, we're going to be keeping them there for the time being. So we're going to be managing that. We're doing some other preliminary assessment. I think I might have mentioned yesterday also that we're going to do serial testing on a group of patients that are coming into the hospital to see if they're negative on one day, positive on another day, or if we can truly believe that that first day negative is a true negative and that we're negative throughout, or if we just need to test 2 days in a row. We're just trying to sort that all out for ourselves so we have the best information we have and we protect our population the best we can. A point to that also is this uncertainty about when somebody might be shedding or not shedding. I want to go back to a point we made a day or two ago about masking more regularly, that can help improve the social distancing. So if I'm standing 6 or 7 feet away from somebody and I sneeze, there's water droplets that will spread into the air and they may potentially still be exposed. If I'm masked, it'll dampen that. So it's common sense. It's not going to prevent the disease. I hope people recognize that wearing a mask around in the community is not going to avoid getting exposed, but the social distancing piece of that is the most important part that will help decrease the spread of water droplets into the air. I think that's the take-home message from that piece. The last few days I've been hearing increasing information, and I think there's been some questions about convalescent serum antibody testing, more rapid testing availability. And there's a lot of hope associated with that. The American ingenuity is phenomenal, and we're going to get information more readily and more rapidly. The importance of the antibody testing is that we can determine then if somebody's been exposed previously, they've developed immunity, and then those are persons that, in two ways that's very helpful. One, their serum can help provide antibodies to another individual. There's this convalescent serum therapy that's being initiated in the United States now. The other way that it's really helpful is we can recognize that if somebody's immune, we think, just like a vaccination would provide. So if they're tested and they have antibodies, they're safer in a sense to work. And the more people that develop antibodies, the closer we get to herd immunity, so that in our community there'll be enough people that are no longer infectious so that or unable to spread the virus, and so we can reduce the risk to those that aren't protected. And we hope that with that and with the dampening that goes along with social distancing, etc., that we can ride this out, keep it at a slow burn rather than an accelerated burn that we've seen in other parts of the country, and get to the point that we have a vaccination and be able to get everybody protected and put this behind us once and for all. But all those things are promising, all those things are very helpful, but there's only a singular thing that's going to stop this disease in our community right now, and that's social distancing, shelter at home the best that you can, recognizing that we all have limitations in the ability to do that, but if you have to move out into the community, do it thoughtfully. Stay separated from others. If you go to a store and you see people aren't following that, find another store. The social distancing piece of this is going to protect us more than anything else for the foreseeable future. Think about this one point. If we were able to have 100% social distancing, everybody stayed 10 feet away from anybody else, anybody with the virus was self-isolated until they were symptom-free. We could kill this virus in a month. It can't survive by itself. It needs a host. It only lives in a host for a certain length of time. Then it goes away, and they recover, or they have the healthcare issues that go along with that if they end up in the hospital, that 15%. But in a month, you could shut this thing down. Now, is it possible to have 100% success in social distancing? No, it's not. But the closer we come to that, the better we can do in putting this thing behind us. So everything everyone can do to help us with that, please work on it. That's my spiel. Any questions?
Dr. Wilson, we have one from Facebook. Does the viral load a patient gets in exposure dictate the severity of their case?
There's some thought to that. A couple of comments to that. One, it takes a certain viral load to get infected. I mean, if you get a small inoculum, you could not get infected. And the larger the load, the more regularly you're exposed, the higher the risk. But I don't believe there's enough information to say whether or not a specific viral load will make the infection more severe, because remember how viruses work. They get into the body, they attach themselves to particular cells, in this case in the lower respiratory tract, and then they insert their genetic material into that cell and basically take over the cell's machinery, killing the cell. So it ultimately produces itself and makes more virus, and then it lyses the cell and goes out into the system and attaches to other cells with all the new little viral particles. So that's a that's a phenomenon of viremia, when the cells lyse and it releases more virus. That's when you get spike a fever and you feel sick, and then it attaches to more cells and it gets quiescent for a little while it takes over the machinery, and it recycles like that a few times until we hope we develop an immunity and it goes away. So once you get an inoculum that allows an infection to start, depending on the individual's immune system, their vulnerability to the infection, etc., it's going to propagate more or less. And so I think it's got more to do with your own, as a host, how hospitable a host you are versus the viral load that you get to start the infection.
How common is it for a false negative?
Well, that's the comment that we've had over the last several days, and it's really unclear. I'll say this, the preliminary test that we do, the PCR test, is probably very, very accurate if it's got the virus on the swab and you put when you run the test on that viral swab. It probably works 97% of the time, as most of the studies are suggesting. The problem is, are you shedding? Are you getting a good swab? Are you getting it from the right location? The data we talked about a little while back, nasal swabs may be 63% effective, and so almost a third of the time you'll get a false negative.
Can you explain a little bit more about how the shedding process works and how your body may or may not be shedding at the time that you're tested?
No, I don't really think we really understand that. I mean, you heard me commenting there about how the virus is attached to cells and how they move through the body, et cetera. And there's going to be times when there's going to be a larger viral load available in the respiratory tract, and other times when it's really in the cells doing its machinery to take over, and it remains unclear. There's increasing information about asymptomatic people, so before they've ever been sick, shedding virus. And there's information, as I mentioned before, about patients that on one day might test positive, another day might not. So it's how and why, I wish we knew. All right, thank you.